Welcome back to
Again.
episode 22. This definitely isn't the second take.
No, definitely not. Or third.
Yeah.
For the most part, we actually do generally shoot it all in one take. So
Yeah, for the most part.
when you guys laugh at all my misnomers and mispronunciations,
We just let it rip.
we just...
I cut out all my errors and none of his.
I
just
really
kidding.
think he does.
No, I just let it ride. Literally the only editing I do is if there's too much dead space. I just kill that, which
I was
isn't
thinking
often.
about that after the last one because I had a big long pause and I almost text you. I was going to be like, can we get rid of that?
I usually do.
Because I needed to.
It's one of those
remember
things where when I'm listening to it, if it's long enough that it triggers my attention, because I'm usually doing something else, but if it's long enough to trigger my attention, I'm like, oh, I need to kill that real fast.
Let's knock that out.
But episode 22 of the Full Code Podcast.
Yeah.
Ron Dees, nurse practitioner.
Clint Cloud.
Perfect. We're on video today. People may or may not see this.
Hopefully they don't see this at this point in time. This is a test run. We are trying to improve our platform. So we're trying to get some video incorporated, be able to post on, obviously, YouTube, potentially some other streaming sites. I know that, as we've talked about previously, there's been some things that would do better with an illustration or a screenshot or those types of things, maybe even a whiteboard type deal. So once we get some type of a studio setup rolling, we're trying to not only be able to incorporate this beautiful, lovely audio, but some video as well. As we've told you guys before, we're kind of on a travel setup, which, tooting our own horn, and to give my guy Ron Dees over there a big shout out, the quality is pretty dang good for having a mobile setup, but video is a whole nother
Can of worms.
wrench in there to kind of make this mobile setup possible. So maybe have a little bit more fixed studio space in the future. But
Yeah, we'd reference the
funding.
full code brought to you by
Dr. Terrence Coulter.
Dr. Terrence Coulter. So we had planned to talk about brain death. I was thinking while you're I said that I'm going to shunt right back to what we were talking to. Anybody who doesn't watch Dr. Andrew Lee, he's a neuro-ophthalmologist. Clint absolutely hates his videos.
Two things that I loathe the most in the same sentence: neuro and ophthalmology.
Eyes and brain. If you're into any of that stuff, he just does like these, what I think is probably like cell phone camera pointed at a whiteboard, and he's just like middle of the day teaching,
Just riffing.
Yeah, and it'll blow your mind. Like, dude's a genius.
Yeah.
Good stuff. I know one of your personal favorites is Annie Sikoria.
Oh, man.
Yeah.
Just keeps me awake at night. I love thinking about it so much.
I sent you is like the new Anna Sikoria video, and you're like, I'm not watching that.
Absolutely not.
I don't care.
My least favorite podcast that we've done to this date
was Anna Sikoria.
Oh, yeah.
I believe it. That's one of the lowest, I think, listened to. People are like, this sucks. I hate
When they
this.
look at the title and they don't even know what the word is, they're like, skipping that one.
Not gonna go there. Not gonna go there.
That was a Ron D specialty. I know everyone's shocked to hear that you were like, oh, let's talk about this.
Let's talk about brain stuff. I just, as we're talking, got an email from Chest, which is talking about RFK Jr. releasing the quote much anticipated Make America Healthy Again report, which I've not gone through, but I did watch a video about it yesterday, and I don't know if this is true, right? Because obviously, when you watch the news, like things can be taken out of context.
Yeah.
But one of the alarming things I heard was that pediatric cancers have risen 50%.
It's probably all those vaccines.
Don't start. Don't start now. I can't. My fragile heart cannot handle this.
Yeah. So pediatric cancer has gone up by 50%. Huh?
Yeah, that's what they say. I've looked no further into that, but I saw that and I was like, ugh.
I think that's going to need some more reading and discussion, because that's, like you said, that simple one-line statement could open up a whole lot of arguments on either side of things. So I think I need a little bit more information.
Yeah, and for those that care, nerandomilast shows promise in patients with progressive pulmonary fibrosis.
Is that a
Don't ask
new
me, I
type
don't
of
care.
antifibrotic drug? I did know that there was supposed to be something coming down the pipe in the world of antifibrotic agents. Right now, the only two that we have are pirfenidone and oh man, now I can't think of the other one right now. Esbriet.
Yeah,
So
I knew that.
yeah, I know you did. You and your
Was it the other day when
Dr. Patel
was like, you want to get pimped out about ILD? And I was like, no, I do not.
Yeah.
And I'm down for a good pimping most days. Like, I mean, it always hurts and I'm always wrong.
Yeah.
But that one I was like, mm-mm.
I got pimped on ILD and I was feeling pretty confident. But the funny thing about getting pimped is they just keep going until they make you not feel confident.
You might
so
be
I'm
wrong.
like, oh, I'm doing pretty good. Tell me this.
Yeah.
What about this? What
if this,
I don't
then,
know.
then. Yeah, you'll start off pretty strong, and then by the end, you don't even know.
Please describe in detail the Ehlers-Danlos reflex. I just made that up. That's not actually even a thing.
I was praying to God you weren't going to explain whatever that was.
No. All right, so brain death, or shall we say death by neurologic criteria?
Yeah, but before we get started, we got a couple things, right? One, T-shirts now available.
Hey.
So we got crew neck, and then the other thing you criticized me for was V-neck, which
I
people
criticized
asked
the
me
people,
for V-necks. So
I
put 'em up.
criticized the people asking for V-necks.
Yeah, I need to. So I haven't ordered one for myself yet because I am really curious about the quality. I got turned on to Bonfire, and it's great because obviously it has a lot of options, but I don't really have to do anything other than upload the design, and then they just go. So T-shirts available. Check the Facebook. I need to have a better way to do that, like an Instagram link tree or something. But I'm gonna try and get coffee mugs. I'm trying to figure that out.
That'd be nice,
and then,
especially in the hospital setting.
Yeah, and then I have a friend of mine runs a sticker. She makes stickers and does designs. So I'm gonna try and do a little collab action there.
Put it on your water bottle.
Yeah,
I'm holding it up for video, so people can see I have my chest sticker on my water bottle.
Big chest guy.
Big chest guy.
Big chest guy. So that's happening. Obviously, we're doing video right now. We were going to start working with a sponsor in the very near future.
Not only crew necks, but we have sweaters.
There's
a hoodie. There's
sweater,
like a regular
hoodie,
sweater, hoodie.
Yep.
Is there a long sleeve?
Maybe.
I don't think there's a long sleeve option. But this isn't, there's different color palettes too. So, I mean, the design is the same, but you can pick different colors, that kind of thing. So, I encourage you guys to go out there and check it out. We don't have a Patreon. We, potentially sponsor here in the future, but we've talked about this before. This is all unfunded. All these proceeds are going to go to furthering the cast.
They're funded, just not.
Well, let me finish my statement. All these proceeds are going to go to further funding the podcast and into Ron Deese's wallet, because admittedly he did a lot of the purchasing of this fancy equipment that you now potentially see up front. So offset some of the initial financial burden and help fund us.
Let me tell you. So when you do Bonfire, I'll tell this for transparency purposes, right? So when you're doing the Bonfire, one of the cool things is that it'll tell you how much money you're going to make. So I was looking at that, and the money that you make is not a lot. Like, it's
$2.
Now you can adjust it, right? If you wanted to price gouge, you can,
right?
But you're making like $2 to $3, right? Yeah. So it's nothing huge. Yeah. But you go in there and like they essentially a lot of them they'll set really high. So when you look at like the sweaters and stuff, I actually priced those down kind of significantly from what they had put, because it's more just like putting some stuff out there.
Yeah.
And it's like you're not trying to make and I am not going to offset the cost of all this equipment.
Absolutely not
on $3 T-shirt sales.
not selling 7 T-shirts at a $2 margin.
But shout out to Jim Cloud.
Yeah,
first supporter.
Hey,
unbelievable.
I unashamedly sent it out to my family group text, and I've helped support some of our other families, startup businesses and things like that, and generally buying a T-shirt for that or something like that. So I'm the only one in my family who works in medicine, but I sent a link out. Hey, support the Full Code Podcast. Get you a T-shirt. Yeah. So, thank you, Jim.
So if anyone's got one yet, I know there's been maybe like 5 or 6 orders, something like that. Like I want to hear. One of our nurses, Kyle, he was. I think he picked one up, and he's like, "I'm gonna wear it, and then when I'm gonna wear it when you're here, and I'm gonna make you sign it." I was like, okay.
First autograph.
So yeah, we got that rolling. We got a sponsor onboarding. Definitely, it's just when.
Yeah.
What else? What else we got going? So event wise, we talked. Impella's coming up. Chess is coming up. I think that's it for this year. Oh, event conference right in October.
which we're both going to be speaking at.
Yeah, dual. I'm trying to figure out how we can schmooze them into like doing this setup.
And like we could record,
like
and
live
do
podcast.
That'd be interesting. We get a cast out of the deal, and you get to give your lecture. That'd be kind of cool.
Double dippy.
Yeah,
we'll give our lecture.
Makes it easier for us.
Yeah,
fall is shaping up to be pretty busy,
like
we talked about. Like there's going to be a lot coming down the pipe. So
yeah, we got a lot cooking. So we're going to talk about brain death before we get started. Obviously, all this is for educational purposes only. None of this is to be considered medical advice. If you have a medical issue, please seek guidance from a qualified healthcare provider. These opinions are our own and do not reflect our organizations or affiliate organizations. And obviously, it's your responsibility to look all this stuff up. So we're not going to talk about any patient cases here, but obviously when we do, the details are changed.
This is just some questions that you've gotten, I think, more predominantly here lately with people having some interest. It's something that admittedly, I think that at least at our local institution, we do a pretty good job of, I think, getting to the end point, whatever, parentheses around that, the final point or the final patient destination without having to complete all of these studies. I think that we're generally able to give a pretty good prognostication to families, quality of life, that type of thing. And generally, I think we're able to kind of come to some type of a decision or agreement, whether that's, end of life care, comfort measures, transitioning to a long-term facility without having to perform all this testing. So admittedly, in the years that I've been working in critical care, which is, over 5 as an APP, I can think of, it's more than a handful, but it's not a significant number of times that I've been involved where we've had to do all of this neurologic testing, potentially ancillary testing with, further imaging studies and stuff. So just saying that as a caveat to where I think that a majority of the time we're able to kind of get to where we need to get to without having to do this. So I do think it's good to go over as well, because it's not something that even for myself, I don't know about you, especially from your experience previously in a lot of neuro, but it's not something I'm doing on a day-to-day basis by any means.
We did it all the time.
Yeah, I kind of suspected that you were going to say that, honestly.
We also did, and I don't know, obviously regionally it's different, but up there we did a lot more organ donation. So we were doing this all the time. So what is brain death? Ron? And I'm going to be honest, there's not a lot of weeds in here, right? Yeah. Like this is pretty straightforward, but so we'll go through some definitions of brain death, right? The first is, and this is very short and sweet, brain death is the irreversible loss of all functions of the brain, including the brainstem. Yeah. Keyword being irreversible.
100%.
And second keyword would be function. And we'll get to that in a little bit.
When I was going through some of this, they were even going between irreversible and permanent, right? To illustrate the fact that this is not something that can be fixed or improved by another clinical intervention.
Right. And the general characteristics that define brain death are the presence of coma, apnea, and loss of brainstem reflexes. And we will go further down that rabbit hole. One of the first important points I wanted to touch on, and this came up recently, and it's just one of those pieces of information that I took for granted, but I think it's very important to note, especially sometimes when you're talking to families. Brain death is considered legal death. It is so the Uniform Determination of Death Act, which all 50 states adhere to in some form or fashion. So there's going to be caveats between the states, but it states an individual who has sustained either irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of the entire brain is dead.
Right.
Legally.
And I think that's where we're, segregating these two differences. In the general sense, everyone thinks of death being, shall we say, just cardiovascular, cardiopulmonary collapse, right?
Yeah.
But you can have, maintenance of some cardiac function. You can have, we won't say respiratory function because that's one of the tests that we'll do, but we can keep people alive on a ventilator
for a little while.
Things, for a little while,
couple days.
But this is in every way, shape, and facet, just as significant of a different way of defining and determining death.
Right. And to your point, right? Like we can keep the body alive for a couple of days,
Mm-hmm.
you know, because people often ask, well, if your brain's dead, how does your heart work, right? Your heart's got its own pacemaker,
Right.
so it'll keep going.
Internal automaticity.
Yeah, but eventually you will have complete, you know, collapse of all those systems. So, and I'll go through a couple definitions that I kind of crafted to try and make a couple things make more sense, because I think when we say brain death, sometimes mentally it's hard to kind of grasp what exactly is occurring. So, what does it really mean for the brain to die? Brain death is the irreversible cessation of all brain function, including the brainstem, due to profound and catastrophic neurologic injury. This loss of function includes the brain's inability to regulate or require cerebral blood flow, confirming the complete loss of neurologic activity. And we'll get into those mechanisms. So the short and dirty of that is you can have any kind of injury that will result in catastrophic ICP rising, where in which the cerebral perfusion pressure cannot perfuse it, right? So
the ICP is so high that no matter the map, right, which in most cases these people are going to even potentially be hypotensive if they're herniating, blah, blah, blah. But yeah, you know, to remember that the cerebral perfusion pressure is the map minus the ICP. So the ICP's sky high. You're getting zero flow. And
tissue dies.
So
and the other component of that is functional disruption. So when you have maybe some sort of trauma, things like a diffuse axonal injury, when you have permanent, irreversible destruction of functional pathways, that can also lead to brain death. Now, in those settings, right, when that brain stops functioning, and we'll get to the quote flow metabolism coupling, which is the mechanism that regulates this, there's signals that stop, and eventually cerebral blood flow will cease. But I want to jump into the mechanisms of brain death. So brain death can result from a number of mechanisms, which include cerebral ischemia, hemorrhage, trauma, edema, herniation, right? Broadly speaking, so here's another definition I kind of crafted a little bit. Brain death can result from any condition that causes irreversible loss of function in the entire brain, including the brainstem, which can occur through catastrophic increases of intracranial pressure that cut off cerebral and brainstem blood flow, or through traumatic injury that directly destroys or functionally disconnects critical brain regions, such as the brainstem or diffuse axonal pathways.
Yeah, that's an awesome definition.
And the reason that I highlight that is because sometimes brain death can be explained or will be explained as the disconnection from the brainstem from the upper cerebrum, which can technically be true, but it's not always true, right? Because like we said, if you have an ischemic event, you have a catastrophic ICP rise, then that blood flow will cease on its own and the brain will die, versus you can have some form of trauma that disrupts that functional pathway. So we had already hinted at cerebral blood flow hemodynamics, intracerebral hemodynamics, and you know, you often get the term tossed around, cerebral perfusion pressure, right?
Right.
So your cerebral perfusion pressure is your MAP minus your ICP, so your intracranial pressure. And as we said before, your CPP must always overcome ICP. So if it cannot, you will go towards brain death.
Okay. Right.
So we had mentioned that component, but I want to jump into the other one. So in the case that that's not the mechanism that occurs, what happens at the tissue level? So this concept is called flow metabolism coupling. So it refers to the relationship between neuronal activity, metabolic demand, and the regulation of cerebral blood flow. The short version of this is neuronal metabolic activity dictates the release of vasoactive substances, which would augment blood flow in states of increased metabolic activity to increase cerebral blood volume.
Right.
So when your tissue dies from a, you know, or is non-functional, right? We'll say non-functional, not dies, but non-functional. There's no more neuronal activity. Your neuronal metabolism drops. You're not excreting those vasodilatory compounds. Blood flow will slowly start to cease, and eventually it will either become static or those vessels will actually thrombose.
Yeah.
And then you'll enter brain death.
I mean, I almost, in a layman's terms, think of what you're describing as a difference between like just straight hemodynamics, perfusion, pressure, lack of blood flow, ischemic injury, as opposed to a, shall we say, more of a metabolic dysfunction, right? So you're saying in this situation you have neurohormonal or just neuron cellular collapse or death. You lose metabolic processes. Your brain no longer feels the need to release these vasodilatory substances to perfuse the brain because metabolic activity is going on. We need oxygen, we need glucose. So when you lose the I guess you could, as we talk about just like cerebral autoregulation, that's part of that, right? The release of vasodilatory or potentially vasoconstricting substances to regulate that CPP within a certain range. When you lose that because there's no metabolic activity that the brain demands these things, that's another way of brain death. But it's not just in the sense of brain death from circulatory collapse or from like a catastrophic rise in ICP limiting perfusion. Is that a good way to think of it? Is that kind of how you're...
And there's kind of like in betweens, right? Because your brain will try and help. Like when you have, an LVO, like a bad stroke, when a lot of times when you do cerebral angiogram, you will see collateralization. So you'll see vessels on the other side of your brain more active and actually shunting over because it's trying. And we won't get down this rabbit hole, but like intracerebral flow dynamics are obviously different from the rest of the body. But, things shift. Like forward flow can become retrograde flow, and things can change depending on what's going on. But I guess the next question to ask is, what does brain death look like clinically?
Yeah.
So we kind of already mentioned this, but complete loss of all brainstem reflexes, and we'll cover what all those are going forward. Flaccid tone without purposeful movement, and the presence of spinal reflexes, and that can be myoclonus, triple flexion, the Lazarus sign. So we've all seen myoclonus, and I think most of us know what triple flexion is. And we'll get into those a little bit later, like mechanistically. And again, it's not crazy. Yeah. Like when you're talking about things like myoclonus, right? We're talking about the fact that your upper cerebrum's not working, but your spinal cord is still intact. Yeah. So there's signals firing, but they ain't got nowhere to go.
Yeah.
So the kind of thing I want to get into is when do you have a clinical suspicion of brain death, right? Because that can be really sketchy territory sometimes.
Yeah.
Because oftentimes people come in and they'll be like, well, they're brain dead. And it's like, well,
that's a very gray
it can be
line. And it can be. And I think that's as we go through the guidelines and everything, I mean, of the utmost importance is that we are excluding any and all potentially confounding variables. So you need to have a very high pre-test positive predictive value to even be going down this route of death by neurologic criteria, right? Because you can't just be like, oh, they had a catastrophic brain injury, they're not doing any of this, let's do brain death studies. Like, no, you need to optimize any metabolic disturbances. You need to, and we'll go through all this stuff, but ensure euthermia, ensure that we are excluding all other causes before we even think about performing this further diagnostic testing for brain death.
Yeah. So I guess the question to ask yourself is, when do you develop a suspicion, right? So the first criteria is you have to have a known, profound, or structurally catastrophic injury that's capable of causing brain death. So obviously that's easy when it's a trauma, when it's a massive hemorrhage, when there's a herniation syndrome, something like that. But one of the topics I'll touch on a little bit later is like cardiac arrest. Yeah. Because that's going to be it's kind of a can of worms.
Right.
And then there are certain conditions in which prognostication must be delayed to correct for brain death mimics. So either confounders or mimics. This can include post-arrest coma without obvious signs of brain injury or on imaging or other diagnostic study which may indicate severe neurologic injury. So what do I mean when I say that? I mean that, and we'll jump to the cardiac arrest here. When you have a patient who's post-arrest, they've gotten ROSC, right? Like, obviously we have all kinds of guidelines for what to do after. But red flag 1, right, is you don't have return of mentation.
Right.
So that's not good. Now, it's not always bad, right?
No.
Like, they can wake up 2 or 3 days later, So that's why you have to keep that in your back pocket.
Well, and it's part of the guidelines in post-arrest care with any type of neurologic abnormality. I mean, you have to wait, you know, a certain duration of time, generally at least 24 hours.
Yeah, usually
mostly recommended longer, depending on what happened in the post-arrest phase and after ROSC. So
yeah. So, and obviously, American Heart Guideline recommendation: if you don't have return of mentation after ROSC, continuous EEG. Right, you need that. And typically these patients are going to get a head CT, right, when they first walk through the door. Now, this is where your red flags start to come, because there are things that can, like we said, and you had mentioned 24 hours, some of those time designations are arbitrary.
Right.
And I agree, 24 hours minimum. Some places will mandate like 72. Some will say 48. Now, to the point of red flags, right? When you come in, if one of these patients comes in, and we're talking in the context of cardiac arrest, you don't have return of normal mentation, they get an initial CT. If on your initial CT you have any of these criteria, so loss of gray white matter differentiation, effacement of the sulci cisterns, diffuse cerebral edema, or the reverse sign on CT imaging. So anyone not familiar, the reverse sign is when essentially there's like your upper cerebrum will start, stop it. The upper cerebrum will be dark because, there's no metabolic activity. And then your posterior fossa, so that's your cerebellar area, is going to be a little bit brighter. And the reason is your posterior fossa structures are often spared because, one, they come from a different vascular supply, and they generally have decreased metabolic demand compared to the upper cerebrum.
Interesting.
So the reverse sign is that you'll have one dark, one light.
When it should be the opposite.
Well, they both should be about the same color. The same color. And then there's the obvious ones like massive intracranial hemorrhage with herniation,
right?
Ungular tonsillar herniation syndromes, bilateral cerebral brainstem infarction, traumatic brain injury with brainstem involvement. Yeah. So those are all like like you're gonna know.
Even severe CNS infections, can ultimately result in death by neurologic criteria.
So, and the point of all that is, if a post-arrest patient arrives and on their initial imaging, they have obvious signs of cerebral edema or loss of gray-white differentiation, your suspicion for anoxic injury jumps dramatically. And at that point, you can almost safely assume that the outcome will be poor, unfortunately.
And that's interesting that you bring up that point, because I did know some of that, not all of that, but that those criteria exist to where, it is pretty standard dogma, shall we say, to have those wait times, especially in a post-arrest.
Yeah.
But in the post-arrest setting, with these initial CT head findings, your pretest probability or positive predictive value goes up very significantly.
Yeah, big time. So let's talk about the interim period, right, when we're trying to rule out mimics and stuff. And so, as you said, we have to knock out confounders first. So low-hanging fruit, sedating medications, anesthetics, or paralytics, right?
And in the guidelines, they list medications, how their metabolism and clearance can be affected by potential any other organ failures. And I believe even in the guidelines is for certain medications a duration of time that needs to elapse to ensure clearance.
Yeah.
If it's a drug that you can check serum levels on, you're going to do that. So 100% medications, and make sure there's no lingering sedation, confounding variables with any type of medication that's been administered.
Yeah.
It's going to be of utmost importance.
Yeah. And again, a lot of those time frames are a little arbitrary, because some will say things like 3 medication half-lives depending on the medication. Right. Some, like when I was, at least at the time when I was doing this, they had like a specific number, like it needed to be X hours since last dose of any sedating medicine.
And obviously this is going to be confounded by, is this primarily hepatically cleared, or is it renally cleared? Do they have baseline CKD, or do they have cirrhosis? So that's why I'm saying, it's all going to change and alter based on the patient's underlying comorbidities and ongoing physiology. So it's not a clear-cut answer. It's going to differ on each patient. So you're going to have to look at that stuff and make sure you're getting that correct.
So drugs, hypothermia. So, and the temp cutoff for that generally less than 32 degrees Celsius. So, and that's cold. That's like 89 degrees Fahrenheit. So
in the guidelines, I want to say that they say that you need to be above. It's either 35.5 or 36. I was going 36. Yep.
So hypothermia, metabolic abnormalities, so hypoglycemia, hypernatremia, hypercalcemia, even, and states of severe acidosis. And then the other one that's obvious, and you kind of insinuated this, is presence of things like hepatic encephalopathy or uremic toxemia.
Yeah.
So one of those. So whether, it's their, like you said, you'd mentioned if they're in any form of severe renal failure, which they might be, right? In a post-arrest scenario, they can be shocky, their liver can be dysfunctional. A lot of times you can have a transient early hyper, elevation of ammonia, or if you have, acute renal injury that becomes, profound very quickly, like if they're very shocky and their BUN, shoots through the roof and they become, uremic, that can be a confounder as well. What else? Yeah, so all these things need to be corrected within whatever time frame is set prior to even considering doing brain death testing. Right. So what do you do before initiating brain death testing? One, like we said before, when you're establishing your clinical suspicion, you need to establish an irreversible cause of coma, which would be consistent with brain death. And then you must exclude confounding factors. Now, coma versus brain death, right? So, essentially they can look very, very similar. Coma, you tend to still have the majority of your brainstem reflexes. You're just completely unresponsive.
Right.
Now, you can have dampening or loss of some, but the underpinning of coma is this is typically either a reversible or improvable state, kind of what you were mentioning before, versus brain death is not, and that's the complete law. Are you yawning at me right now?
I held it in. No one heard it.
It's 9:30 in the morning.
I told you I had my son's last day of school yesterday. It was a busy day.
Yeah. People can't see this, but your son's actually under the desk.
Yeah. If you hear any knocking, it's because we had a fun last day of school. Yeah. We did fun activities, rode dirt bikes, and we had a sleepover and watched the Minecraft movie last night. Yeah. So, yeah, I yawned a little bit. Sorry.
That's okay. I forgive you.
Plus, you're just dragging on.
Okay. All right. Don't make me dig up the renal physiology. I'll play that at your funeral.
I love me some renal phys.
Okay. Any glomerular cells?
No, I think that I think I made this statement before. I just am trying to reiterate that everything that you're listing off, right, is there's a whole lot of more things that are going. A whole
lot of more, baby.
A whole lot of more. There are a lot more things that are going to make you take a cognitive pause or a stop to think, can I even perform brain death criteria?
Yeah.
As opposed to the other. Like, it's not like it's just you go on. There are a lot of things that we need to exclude first. So you're always erring on the side of caution, right? If we're going to make the clinical determination that this patient is brain death, we better make dang sure that we're taking the cognitive space to think through all other potential confounding factors before we make this diagnosis and pursue this testing and put that, that burden on the family and that kind of stuff. So,
and that's why in a lot of places, I don't know that we do this, but in a lot of places you have to have two physicians do it with a certain time distinction apart.
I looked into this. So it's state dependent. Generally, if all the criteria are met on the brain death exam, so I'm talking, as you've talked about, the absence of brainstem reflexes that will go through, the very in-depth neurologic exam, the apnea test, then for one, you do not have to perform additional testing, specifically advanced imaging, although it is still recommended as a second backup. And you don't have to have two physicians perform it depending on the state. But again, it's highly recommended. In the adult population, there was not a time frame on when one provider and the other had to perform the exam. In the pediatric literature, they did still incite a 6-hour window between exams by two separate providers. From what I can find, there was not that distinction in the adult literature. But again, I keep reiterating this, we're erring on the side of caution, right? So this is not a one test seals the deal. This is do all tests, gather as many data points as possible to ensure proper diagnosis and confidence in that diagnosis.
Yes, good point. I'm just watching sandals fly across the room. Okay, so brainstem reflex testing. So this is the core of the initial brain death evaluation.
Yep, here we are, 35 minutes in, and we made it.
Wow.
To the core.
We're near the end. We're right near the end.
I know. I'm just giving you
so this is the basic exam that's going to be performed by a qualified healthcare professional, whether that's a neurologist, an intensivist, or a mid-level, whatever.
And, I kind of looked into more of this stuff, right? Like what's the stipulations on who, what, when, how many.
Because we've talked about this a few times.
So, again, this is going to pin state regulations. It needs to be performed by a provider who specializes in that area. So if you have a neurocritical care specialist, like they're probably the ones who should be doing it. Mm-hmm. It can be performed by an APP who has had additional training. Now that training may only be that they've performed one exam under direct supervision, kind of like how you would do a sign off at your regional facility for procedures and that kind of stuff. If that's deemed appropriate within your facility, then that can count. There is additional training that you can get through neurocritical care societies, potentially through ENL, so there are like certificates and training that you can achieve through other things that are going to make you obviously a more robust practitioner to perform these guidelines. But that's kind of what I gathered as far as who can perform the exam.
Yeah. And I know this is an ongoing topic of, discussion in terms of, because we've talked about doing this here a little bit, and and obviously you're one of the people who is involved in understanding the credentialing process and how people are privileged to do the things that they do. Because I think a lot of people think that you just come in, I get a ton of questions about what's the process like when you become a mid-level, and it's like you have credentialing, privileging, all this junk,
Right.
So getting that up to a speed where your hospital formally recognizes your, privilege to do so and your competence to do so is not a bridge that's easy to cross.
Even though you had to perform 20 proctored sign-offs in PA school or MP school or whatever you had to do, that does not count, unfortunately, for immediately being hired into your facility. You still have to, unfortunately, go through the re-credentialing process. So you're like, well, I just did all of these in school. Nope, you got to do whatever your institution decides, X amount of proctored procedures.
I feel like that's why a lot of academic institutions are starting to lean away from getting real lab heavy these days, because it's like you're going to start all over. Two, you're going to be taught to do it with the equipment that you have in your place and the methods and approach that they approve, So not that it's even really that different, but,
And, admittedly, at least at our facility, right, as I alluded to earlier, this isn't something that I see happening on a day-to-day basis, at least in the patient population that we're caring for. Maybe with our neurocritical care colleagues, they are. But in our institution, we have neurology. They obviously round on critical care patients, but critical care, us as a medicine team, kind of help manage medical conditions.
Oof.
Excuse me.
The allergies be hidden right now.
Well, and I told you, we rode around in a big field of hay yesterday while we were riding dirt bikes, and the grass grew quite a bit since the last time we were out there. So I think I'm just,
I woke up sneezing this morning.
So, excuse me.
My eyes opened and it was like bam, bam, bam. Yeah. It was terrible.
They be hitting.
Yeah. Anyways, brain death testing.
Yes.
So obviously first is you're establishing the presence of coma, right?
Yeah.
So no responsive verbal or painful stimuli, step one. Two is pupillary corneal reflexes. They'll both be absent. So again, we beat this to death. Your brainstem reflexes will be gone.
Correct.
Gone. So you had mentioned both your oculocephalic and your oculovestibular reflex. Did you want to give us your little rundown?
Yeah, well, I am aware of these. Admittedly, these are not diagnostic tests that I'm performing during every physical exam that I do it all the time. Yeah, I'm sure you do. I have performed the oculocephalic reflex quite a few times. The oculovestibular reflex, I feel ashamed to admit it sitting here on this podcast as a critical care, as I deem myself special. I'm not a specialist. I'm very mediocre, but I do not think that I've ever done the oculovestibular reflex.
So the oculocephalic reflex,
cholerics,
yeah. So your oculocephalic reflex, that's your doll size. That is not complicated.
No.
You open the eyes, you tilt the head.
In the absence of a cervical spine injury, guys, right? Like,
obviously,
if they're in a C-collar.
C-spine. But if you have an intact brainstem, right, your eyes are going to, like your eye control is going to be target fixated.
Right.
So when you turn the head, the eyes should stay forward.
Correct.
Right. So when you have severe brainstem damage, when you do that, your eyes will be conjugate.
If the eyes follow the head, whichever way you're moving it, that is an abnormal response, and you have lost the brainstem reflex to keep those eyes fixated.
Yep, that is the big sad, big frowny face. Now, I won't fault you at all for not doing cold cholerics because it, like, to do it proper, right, you have to have a bunch of ice water.
Yeah.
You get a big old Toomey syringe, get like a J loop for an IV, cut the tip of it off, connect it to your Toomey, get a bunch of ice water, and get a lot of towels. So you stick it in there, and then you're just shooting water.
This makes me feel like now you're an acute care trained nurse practitioner, so you didn't really have to do any outpatient clinicals, right?
No, none.
This makes me think of my days whenever you were rotating through family practice and the little old lady comes in just for a cerumen impaction and you're just like irrigating the crap out of their ear there in the office. This is kind of what I feel like you're doing.
Well, see, I thought I had dodged all that stuff because that was like, and we've talked about this. I originally wanted to be family, and then I was like, I think I'm actually going to go back to the hospital. But then I was reviewing like the clinical requirements. I'm like, acute care it is.
Yeah. So, so what are we looking for in this sign? Do you want me?
Well, I mean, it's pretty straightforward, right?
Yeah.
Like I know we've talked about this. It bores people to death, so we won't talk about it a lot. Your eyes maintain conjugates by oppositional force, and there's all kinds of mechanisms that rule that, right? So when we're shooting cold water in there, we're essentially trying to slow down that synaptic response enough to see if your brain will compensate for it, right? So in a normal person with a functional brainstem, you shoot a bunch of cold water in there, your eyes are going to tick one way, and then you're going to get nystagmus the other way, and then you're going to vomit a lot.
And it should be, at least whenever I was looking through this, the initial movement should be to the side of the irrigated ear. That'll be more of a slow movement towards the side of the ear being irrigated, and then quick lateral nystagmus to the opposing side. Yeah, and that's a normal response.
Yeah, because that is the slowing, and then your brain going, and then shooting it back the other direction.
So that's the appropriate, almost over-regulated compensatory response because of the cold slowing the synaptic transmission. Right?
So, and a good example, right, is in ischemic stroke, right? So if you have a right-sided infarct,
right, you get that.
That right control's gone. You'll get gaze deviation, gaze preference toward the affected side. Seizure, another good example, right? You get an electrical stimulus in some area, and it pushes. It's oppositional, so it goes the other direction, which is why in seizure you have gaze deviation, right? Yeah. But in a negative test, obviously, nothing happens.
It goes without being said, right? Yeah. Like it should go without being said that you don't perform the oculocephalic reflex without, them not being in a C-collar or having a cervical spine injury. You have to look in their ear, okay, especially if they had a TBI. We have to ensure they have an intact tympanic membrane.
Yeah, you don't want to shoot ice water.
That we're not shooting ice water into their middle ear. We're going to predispose them to an infection, mastoiditis, something like that. So, obviously you have to ensure that you have an intact, functioning middle ear, tympanic membrane, all that kind of stuff. Right. So,
yeah, and if anyone's into this, there's a lot of really cool neuroscience as far as how your endolymph and your different systems in your inner ear can really dictate your balance and movement and target acquisition and stuff. And it's even, I think of it in the realm of like, have you ever seen any of the studies about like the ridges in your pinnacle, so your in your ear?
Yes, like, and how it like directs sound. Is that what you're talking about?
Yeah. When they've taken clay and stuff and they'll mold it around so you lose the ridges in your ear. Because they didn't quite understand exactly what it was, but that's how you tell where something is in space.
Yeah. So I wonder if people with cauliflower ear have bad
That's a good question.
orientation.
I've honestly never thought about that. I would assume so, or at least reduced, right?
Just got to find some wrestlers and UFC fighters and
well, there's a good amount of people who do the jiu-jitsu here.
the BJJ.
Yeah, the BJJ. Okay, so yeah, those are the two reflexes, and then obviously gag and cough are gone.
Yep.
So we already made note that a lot of times these findings need to be confirmed. That's very state dependent. All right, really?
I don't know what you're talking about.
Anyways, moving on. So then confirmatory testing, right? So the one we probably do the most, would you say, apnea testing? I mean, this is, this is going to be, I don't want to say your gold standard, because really your gold standard is your cerebral blood flow studies. That's objective.
1,000%.
Yeah.
And that's why, again, I've said it so many times, but the more the better. So the guidelines state that if you go through all this, you have excluded confounding variables, you have corrected metabolic disturbances, you have an exam that we just outlined where you have complete loss of all brainstem reflexes, and then you have a positive apnea test. That is enough to diagnose someone as death by neurologic criteria. Mm-hmm. Ideally, this would be performed by another practitioner. It doesn't have to be, but yeah, this is kind of the last step in the physical evaluation. Now, I think most of the time they're going to still recommend that even if you have all these positive factors, that you still would be behooved to perform some type of additional testing, such as a cerebral blood flow study, TCDs, which we can talk about a little bit. And then the gold standard is not, well, is still a cerebral blood flow study, but it's actually a cerebral angiogram.
Right.
But yeah, so the apnea test, do we want to?
Yeah, I mean, it's not super crazy, right?
No.
So you get a baseline ABG on the patient. Once you have that, you pop them off the vent, and you give them oxygen.
On the ABG, what are we needing to see, though?
Your PCO2.
PCO2 and pH. You just need to ensure that they're normal carbic.
Yeah,
now,
but you would assume if you've gotten to the stage that you've already done that.
True, correct, because that's a good point. You're confounding. But I did find something interesting that they did mention people who are potentially like chronic hypercapnic respiratory failure patients or chronic hypercarbia. And if you can establish their baseline PCO2, then a positive test would be, after the apnea test that you'll outline, is a rise in PCO2 greater than 20 from their baseline, or a PCO2 greater than or equal to 60. But you have to know what their baseline PCO2 is if they have chronic hypercapnic respiratory failure or chronic hypercarbia. If you can't figure out what their baseline PCO2 is, then you still have to perform the additional ancillary testing.
Well, and the other component that is, and obviously we just talked about the PCO2 component of it, but during this process, you're observing for spontaneous respiratory effort, and if there's none, right, that's pretty solid.
Yeah.
But if you see anything questionable for possibly trying to initiate a breath, it's like, and we've talked about confounders before, right? We've had plenty of cases where your patient has no reflexes, they have fixed blown pupils, all these things, but they're still generating spontaneous breaths.
And, that is obviously, to your point, a very poor prognostic factor. What's this patient's quality of life? Are they going to ever have return of neurologic function that makes them who they are? Probably not, but they are not brain dead, because what we're testing here is your medullary chemoreceptors, right? You've got your medullary chemoreceptors.
Shut up, dude. Shut up.
What? I can at least say stuff in regards to the respiratory.
You're such a nerd.
I know the respiratory center
medullary chemoreceptors.
Well, it's initiating respiration. So I know stuff about that from a pulm standpoint.
See, don't ever talk smack about the brain ever again.
We're trying to see if the medullary chemoreceptors are working, and if your PCO2 rises to this certain level and you're still not initiating respiration to blow that off, then we know that those are not functioning well. Obviously, the medullary center chemoreceptor is part of your brainstem. So,
thanks, doctor.
You're welcome.
So, and you had mentioned ancillary testing, but I think this is a pretty short list here.
Yeah, and then I think the only other thing about apnea tests is I heard him talking that it's like, I always thought it was supposed to be about 10 minutes, and if you didn't have respiratory effort, but I guess people go, if they're unsure, they go much longer, as long as you're not hypoxemic.
If you're not if you're not hypoxemic or hemodynamically unstable.
Correct. Yep.
Yeah. But no, I think typically you're right, 8 to 10 minutes, but I have been in cases where we have gone 15, 20 minutes before.
See, and I was a little, I don't want to say shocked. That was just something that I wasn't aware of.
Well, and it is honestly pretty wild. Like when you have somebody who's sitting there and they're not breathing
for
at
20
all
minutes.
For 20 minutes. And you're like, and you get through it.
Yeah.
So you had mentioned cerebral blood flow studies, i.e., primarily this is your gold standard is going to be your cerebral angiography or your digital subtraction angiography. That is your fluoro looking. Typically, when you're looking at that, and I, kind of unrelated but semi-related. When you have your patients who have strokes or any kind of endovascular procedure, go look at the images.
Yeah.
Like familiarize yourself with how that looks. But you, in states of brain death, you will not have flow beyond the carotid siphon, which is one of the segments as you are
work your way
approaching the intracerebral entrance when your ICA becomes your MCA and then your ACA. What else? Radionuclide, cerebral blood flow scan. So there's nuclear medicine, just like when we do.
I like the idea of this just because it makes me think kind of a PET scan. So not only are you kind of looking at perfusion, but you're also looking at metabolic activity, right? Because they prefer that you use one of the metabolically active uptake molecules. So not only are you looking for perfusion, but you're also just able to assess, is there actually any metabolically functional tissue?
You know what it's called when, what the sign is called for brain death in that study?
No.
It's called the empty skull sign.
Ooh. I've seen pictures
there's
it's
nothing.
Pretty crazy.
There's nothing.
Yeah.
I don't know if we mentioned this earlier. I know you were and I were talking about this. You can do EEG, but EEG is not definitive. It can just potentially give you a signal. That's not going to be confirmatory in any way.
Right. But again, more data points, the better. Right?
Well, and kind of what we talked about in like that post-arrest, recommendation for continuous EEG. If you're getting signs of anoxia right early, that can start to kind of cue you off. But then if you go, transitioning from like potential then anoxic signal to like isoelectric signal, that's also, kind of like, maybe you should start looking into this,
I don't want to backpedal, but one thing I feel like we should have probably mentioned earlier when we were talking about cerebral perfusion pressure, cerebral autoregulation, most of the time in the ICU, we're treating patients to target a MAP greater than 65. In these guidelines, you need to target a MAP of 75 or greater or a systolic blood pressure greater than 100. So anything below that is going to be termed hypoperfusion or hemodynamic instability in the setting of trying to diagnose brain death.
Yeah, I don't know if we said that out loud, right? The MAP range is like 50 to 150
for cerebral autoregulation. Correct. Yes. I just wanted to outline that because you may need, from what I can understand, you're not inhibited or it's not preclusive to have someone on vasoactive substances like levofed to maintain that MAP or that systolic blood pressure, but you need to make sure that you've maintained that MAP or systolic blood pressure before you perform any of these studies to make sure that hypoperfusion isn't
beneath you.
Yeah.
Yeah. And the final is transcranial Doppler.
Yeah.
So not the best because obviously it depends on if your patient's got good windows, if you can get good images, but it can work. But realistically, and you can also do CT angiography. It's variable, not always reliable, but that's also an option for you.
Yeah.
Anything to add?
No, I think that's good.
If you flex your quads at me one more time, I'm going to lose it.
I didn't flex my quads.
Your shorts get higher and higher, and you're just like, I'm just, that's all I see from here, just flexing quads.
At least all they can see is my upper body.
Yeah, neither of us are wearing pants.
Shocker. All right. So, yeah, we'll come back with some more things. I don't know what we're going to do next, but we talked about what other things we got coming down the pipe.
I know what we're doing next.
Hopefully that kind of helps outline some of these things that maybe you guys have had questions about. It was good for me to read through the guidelines. If you guys have any questions, feel free to reach out to us at thefullcodepodcast@gmail.com. Like us on the platform that you listen to this podcast on.
Primarily Apple, by the way.
Primarily Apple.
Even though I put everything out through Spotify.
Spotify
yeah.
for podcasters.
Yeah.
Go buy a shirt. support the podcast.
Get a shirt, rep your full code wear, get your tickets for the event conference.
Yeah.
I don't think there's tickets.
I don't think so either.
Just show up.
Get your slot.
Yeah.
And other than that, anything else from you?
No, I have nothing to offer. I'm borderline brain dead at this point in my life.
Yeah. We're both struggling.
It's
bit,
been a
but I feel
rough
like we say
week.
that all the time. We're just in that stage of life.
Well, I just worked a week straight of
worked a
nights,
lot.
and then took a day and a half off, and then came back, and we got smoked yesterday.
Yeah.
We've got a baby birthday party this weekend, and
all the things.
getting silly. I got to edit this and do all this work when someone goes to the lake.
I'm not going.
I'm just kidding. I'm messing with you.
All right, guys.
Yeah,
that's
no, that's
been episode 22 of the Full Code Podcast. I said all my things already, so we appreciate you guys.
Subscribe, follow for more.
Yeah. And we'll hit you guys back
And
soon.
then maybe you'll see this video.
Maybe. Probably not, though.
Thanks for listening.
Later.